Okay, so let's take a look at some meds now that are typically given for patients that have a heart failure. A lot of these meds are given for heart failure. They're also given for hypertension. So you're going to see these in both of those disorders very commonly. So I'm just going to kind of go over an overview here and then we'll go into the medications themselves. So we have cardiac glycosides, ACE inhibitors, which is angiotensin converting enzyme inhibitors, ARBs, calcium channel blockers, nitrates, diuretics, vasodilators. There's also a new medication that is a direct renin inhibitor, so it acts on the RAS system. All right, have diuretics there. And then anticoagulants. So we'll get to anticoagulants in a moment. It should be at the end of the slide because we've already talked about them, but I want to tell you why we use them with hypertension and heart failure. So the biggie as far as cardiac glycosides are concerned is digoxin. It is an old medication, but it does the job very well, and there actually is still no real good substitute for it because it has two things going for it. It is considered a positive inotrope and a negative chronotrope. Okay, these are important things to know. So the positive inotrope means it positively increases the contraction of the heart. So remember, some of our heart failure patients have this contraction problem where the ventricle cannot contract properly. So this helps increase the contraction of the heart. It also has a negative chronotrope effect, which decreases the heart rate. Okay, so fairly easy to remember because the negative chronotrope, negative decreases, positive increases. Okay. We have the ACE inhibitors that all end in RIL, so the prils, lisinopril. And a lot of these you'll see, just like this one, works with the RAS system as well. So this one, the run-in happens, but it blocks the conversion from angiotensin 1 to 2. So it decreases because of that, it also decreases the aldosterone levels because 2 isn't being activated. So we're going to get an excretion of water, and so that's going to decrease our water retention, and it also then decreases the workload of the heart. Okay. Our ARBs, like losartan, these are typically used if the patient cannot take the ACE inhibitors. ACE inhibitors have a few very distinct side effects that we'll get into, and so if a patient can't use the ACE inhibitors, then they'll use the second go-to is the ARBs. So what this does is it blocks the angiotensin 2 again, but it blocks the angiotensin, which causes vasodilation, and then it basically has the same effects of as the ACE inhibitors. It's just blocking in different areas. Plus, it has a vasodilation effect, and it keeps the potassium and secretes the sodium. Our calcium channel blockers. Oh, also, sorry, our ARBs is also the RTAN at the end, so it's nice to remember. Our calcium channel blockers, though, do not have any similarity in their names. It's the one oddity. So we'll go over that when we take a look at them, but they literally block or inhibit the transport of calcium to the myocardial. And so remember, calcium, if we have too much calcium, we can get tetany, we become rigid. And so this inhibits that, so it relaxes. There's less contraction, it dilates, there's less excitability in the myocardium. So I like to call calcium channel blockers like Xanax for the heart or Ativan for the heart because it just relaxes everything. And that can actually decrease our blood pressure. And our oxygen consumption, which is great because if it's relaxed, it's going to be slower, and so you're not going to have that oxygen consumption as much, and it dilates as well. Some of these medications also have antiarrhythmic properties as well. So our nitrates, so our nitroglyceride or isosorbide, they're direct vasodilators on our coronary arteries. It just dilates everything really quick and does a great job. Diuretics, so our loop diuretics are thiazide and then our potassium sparing, causing diuresis in different areas of the kidneys, so decreasing the fluid, therefore decreasing our blood pressure, therefore decreasing the workload of the heart. We have vasodilators, specific, so direct vasodilators, which is one of them is hydralazine, great, really, really good drug, and it's a direct arterial vasodilator. And then the one thing that I'm missing here is the beta blockers. How can I forget that? So our beta blockers, as we have looked at them before, they work on our sympathetic nervous system, blocking some of that sympathetic response, which will decrease our heart rate and decrease our blood pressure, which then also decreases the workload of the heart. So I've said that a lot. I've said our cardiac output needs to be sufficient, and then we need to, when we have problems, we need to decrease the workload of our heart, because decreasing the workload of our heart actually decreases our oxygen consumption, and it gives the heart a rest while we try to fix the problem or maintain the function that's happening. So if we put too much stress on the heart, it's just going to make things worse. We're going to have too much oxygen consumption, then our cardiac output will be decreased, and then we'll go straight back into those compensatory mechanism, which can cause a flare-up or an exacerbation. And you will also very often see patients come in with CHF exacerbation. So let's get into the drugs themselves. So our cardiac glycoside, so our digoxin, remember, positive inotrope, negative chronotrope. So it increases the contraction and it decreases the heart rate. Therefore, it increases the cardiac output. It also increases cellular calcium, which then decreases the amount of calcium that is in the myocardium. So indications are for heart failure, dysrhythmias, and atrial fibrillation. And left-sided heart failure, systolic, so left systolic dysfunction. Think of it this way, because left systolic is a contraction problem, so you're not going to contract that ventricle very well, and so this increases the contraction. So if you specifically have systolic dysfunction, this medication can help with the contraction. Okay. So our nursing implications have a lot to do with what this is actually doing. So if we have an AV block, which I know you haven't gone over yet, but it is a block in the AV node, which decreases the heart rate, then it would be contraindicated for digoxin, because digoxin decreases the heart rate. Okay, so if you have something going on, don't think about this as just an AV block. Just think about anything that the patient has that causes a decrease in heart rate already, then that might be contraindicated. Contraindicated doesn't mean that we can't use it. It means that we need to use it very cautiously. Okay, we need to monitor for arrhythmias, because if we're messing around with the heart rate and the contraction, the patient could get arrhythmias. This also might be for dysrhythmias. Now, as you know, we need to assess the blood pressure and the apical pulse for 60 seconds for 1 full minute. This is the only medication that you need to do that with, but you have to do it, okay? Because you're looking to make sure that it's a full, the rhythm is regular and your heart rate is at least 60. to give this medication, because if they have slight irregularities in their heart rate, then that is going to possibly decrease or even increase their heart rate. But if you haven't listened for 60 seconds, then you don't know that. So then that would be a unsafe med administration. So you need to check this BP and apical heart rate prior to administration and then post administration as well. Okay. Again, don't call. If the heart rate is less than 60, then call the MD unless they have parameters written already in your chart. This patient should be monitored with an EKG because this medication can cause dysrhythmias, remember, and it can even decrease the heart rate so much that you might go into a block. You can give this IV. It comes in a tablet form. It comes in IV form. If you are giving it IV, you need to watch out for infiltration because it can cause some damage and affects the skin if infiltrated. Monitor for arrhythmias, bradycardia, and hypotension. And then also toxicity. So digoxin is one of those medications that we have to look for toxicity. Toxicity with digoxin can be, what I'm trying to say is we can look at things like their labs, for example. We can kind of sidestep it. We can prevent it from happening if we're monitoring them properly. So one of the key signs is hypokalemia. So if we're looking at that lab and we have like a really low potassium level or consistently on the lower side, we might want to get a DIG level because hypokalemia can cause DIG toxicity. Okay, it's one of the leading causes of DIG toxicity. So if your patient is at 3 for their potassium consistently, then you might want to ask the doc for a DIG level to make sure that they are not becoming toxic. The levels for that DIG should be 0.5 to 2 nanograms per milliliter. And some signs and symptoms of that DIG toxicity is nausea and vomiting, kind of, out of nowhere. They're fine, but they have some nausea, vomiting. They have some vision changes, bradycardia, hypotension. The vision changes are kind of strange too. Sometimes they'll see halos of color. And we do have an antidote for digoxin, and it's called Digibind. So if there is any type of toxicity, hopefully we catch it in time and we can give them Digibind so we can reverse the effects of digoxin. Our next medication is very, very common, our ACE inhibitors, so lisinopril. As you can see, I've got the PRIL here bolded and enlarged for you. And the action for ACE inhibitors is vasodilation, plus it also blocks the conversion of angiotensin 1 to 2. So it does that whole decreased aldosterone in levels, keeping the potassium and excreting the sodium and water. So obviously we need to monitor their electrolytes. It is used for heart failure, hypertension, MI, sometimes angina, lots of different indications actually. It's a very good drug. It works very well, but these are the ones we're going to highlight right now. And there is a drug-to-drug interaction for allopurinol. So that would be a medication taken by a patient with gout. So when we're seeing implications, we need to monitor their kidney function because, if it's working on the RAS system, it's working in the kidneys, so we need to monitor the kidney, assess their sodium potassium levels, monitor their vital signs. Again, all of these medications, okay, we're going to monitor their vital signs because this is working on the kidneys as well. Then we need to monitor their blood pressure, okay. We also need to monitor their heart rate because we could become too bradycardic. And of course, we're going to do that prior to and post administration. We need to monitor their weight. Maybe they're not getting enough ACE inhibitors, and so their weight is going to go up, just like with a lot with heart failure patients, or we could be giving them too much in there and they might drop weight really fast. If they did that, they would also probably have a decrease in blood pressure. But we're not going to let that happen because we're going to be assessing their blood pressure and heart rate prior to and post administration. And we're not going to be giving this if their blood pressure is less than 90 or per the protocol that the doctor has written in their charts. We're going to assess for angioedema. That is a side effect. Another side effect, which is very important, is something called, we call it the captopril cough. So the ACE inhibitor, it's an easy way to remember it. So it's kind of a spasm, it's a dry hacking cough, and it can kind of constrict your airway. And so if that happens, then they can prescribe an ARB, which is the second line of defense. So from ACE inhibitors, you go to ARBs. Many of these medications as well, ACE and ARBs and DIG, they're kind of co-prescribed. So you might have people on 3 or 4 of these medications, but they're all in smaller doses. And because they work in different areas of the body, then you're going to have less side effects if they give you a smaller, a lower dose, but for different areas, medications that work on different areas of the body. With the captopril cough, they don't want to cover it up. They need to call their provider right away because it can get worse, and we don't want them to lose their airway. So that is an educational point that they need to know to call their physician. So then our next is our ARBs, which is our angiotensin II receptor blockers. So this blocks the angiotensin II slightly differently than the ACE inhibitors. And so this is what a patient would use. This is the second line medication used after ACE inhibitors. So if ACE inhibitors don't work well for you, then you are going to go to an ARB, such as losartan. And so this is the RTAN. It vasodilates and has the same effects as ACE inhibitors. It's just working on a different section. Again, heart failure, hypertension, this can also, because of the vasodilation properties, be a stroke prevention medication. And the biggest drug to think here for drug-to-drug interactions is phenobarbital. So with ARBs, losartan, our nursing implication, again, it's working on the kidney, so we're going to monitor that kidney function. We're going to assess for hypovolemia. Hypovolemia is always bad with these medications because it could drop your blood pressure quick, and then it exacerbates the effects of these medications. Also, hypovolemia can concentrate these medications, causing more harsh side effects on your body and possibly causing a toxicity. Again, blood pressure prior to and post administration. Hold for low blood pressure unless otherwise stated. Typically hold at less than 90. So you're going to assess your BUN, creatinine, ALT, and AST. And then for this, you want to monitor for diarrhea. It can cause diarrhea, hypotension, and the angioedema. Okay, the angioedema. Calcium channel blocker. So this is the medication that I was telling you is that I call Ativan for the heart. Remember, it's not Ativan. It is not a sedative. I just call it that because it's working with calcium. And unfortunately, as you can see, none of these names are like, which makes this one kind of the hardest one to remember. It's just rote memorization. So calcium channel blockers, verapamil, amlodipine, diltiazem, nifedipine. Okay. Some of this medication in particular and the beta blockers have antiarrhythmic effects as well. And then if you think of this amlodipine, so there is another medication out there called amiodarone. And so I don't want you to confuse that. So think of amlodipine as it lowers blood pressure. Okay, so they are similar in the way that we say the words, and so try not to confuse them. Verapamil, diltiazem, also cardizem. We use these very often. Amlodipine and diltiazem or cardizem are used very, very commonly. So it inhibits the transport of calcium into the myocardial. And so it causes that less excitability and less contraction. So Ativan for the heart, it relaxes everything, okay? It dilates the arterioles, which then decreases the blood pressure and oxygen consumption. So as you can see, because it causes less excitability, these can be used on heart arrhythmias or dysrhythmias, depending on what it is. AFib, we use cardizem all the time for atrial fibrillation. We'll start out with a drip and then go to a PO tab, and it works great. So indications, hypertension, heart failure, atrial fibrillation, angina, all to decrease the workload of the heart. Okay. Drug-to-drug reactions, so cyclosporin, okay, but digoxin, real biggie to look out for here because chances are your patient with heart failure might be on digoxin and calcium channel blockers, okay? So just something to be cautious of, not an absolute no-no. Grapefruit juice, don't we love that? This is one of those medications that it has a reaction to grapefruit juice. And again, just like some of the others we've spoken about, contraindications would be anything to do with heart blocks or renal and kidney dysfunction. Okay. So our nursing implications, it's the same here, blood pressure, heart rate, an EKG with calcium channel blockers because it decreases the excitability of the heart. And so we want to get a baseline cardiac rhythm on them before starting this. To make sure there's not any abnormalities that could be detrimental to the patient. Stevens-Johnson syndrome, you've heard of that before as well. And so this is kind of an allergic reaction that people can get to this medication where we've got those blisters on our skin, and it's really just an allergic reaction. It can be profuse all over the body, but once we stop this medication or whatever medication is causing the Stevens-Johnson kind of by trial and error, then it'll go away. Again, with heart failure patients, assess intake and output and daily weight. Our nitrates. So nitroglycerin, so we spoke about this. Also isosorbide, it's the same family, okay? Isosorbide, a lot of times we can give that IV. What this is a direct acting dilator, so it dilates the coronary arteries. Causes relaxation and depresses muscle tone. So it dilates, opens everything up, works really quickly. Heart failure, angina, helps restore oxygen delivery to the myocardium. Those are the indications. And let me see here, drug to drug. So heparin and concurrent antihypertensives. So concurrent antihypertensives are really the same for most of these medications, but then remember I told you that that a lot of these patients will be on multiple of these drugs, and it's just a matter of monitoring them very closely, and then also educating them for their home blood pressure and heart rate. An interaction is heparin, and a contraindication is head trauma and severe anemia. So think about this. So if someone's taking nitroglycerin, it really is vasodilating really, really quickly. And so if they do get a head trauma and they're vasodilating so that it can that vessel is really enlarged. If they do get a head trauma, because of that dilation, they can actually have a lot of blood coming out. And so it would be contraindicated. Same with severe anemia. So if they're anemic, they don't necessarily want to, they might have to take this, but they don't necessarily want to take this medication because it's an increased risk of bleeding. And that's why one of the drug-to-drug interactions is heparin, because that would increase the bleeding also. So our routes are the common routes are sublingual. That's typically what we're going to give right over here for angina. We're going to give it every 15 minutes until the angina is relieved. And we can give this 4 milligrams up to 3 times. So that would be a 15-minute total. So at the beginning, and then at 5 minutes, and then at actually 10 minutes. So at 10 minutes, they should have received 3 doses. You don't keep giving them the doses though if their angina subsides. So if their angina subsides after the first dose, then you don't give them the other 2. Okay, so you only go up to 3 if it's not resolved. If it's not resolved, you're going to do 1 or 2 things. You're going to either call the MD and let them know and ask for direction, or you're going to follow the protocol that the physician might already have in the orders. The isosorbide, like I said, can be given IV. Nitroglycerin is very common in patches. The patches need to be, the old ones need to be removed before the new ones are placed because of the vasodilation. And what you need to do is you need to have gloves on when you're doing that, because if you're not used to nitroglycerin, it can, just by touching the pads, and this would go for fentanyl patches as well, just by touching them, and nicotine patches actually, it's absorbed through the skin. And so you can actually get a reaction if you're not a smoker and you touch a nitroglycerin or a nicotine patch. It can really quickly drop your blood pressure. So be very careful with those. Use the gloves, and then also do not put them in the regular trash. There should be another container there to put them in, so that we're not exposing our interdisciplinary team that we have and our house cleaners, EVS, to these medications as well when they're cleaning up the room. Okay, very important. You should be on a telemonitor for using nitroglycerin, and the patient can feel flushing, pallor, increased perspiration. These are normal side effects for using a nitrate. And then, of course, if the patient was having an MI, you would follow the protocol that I was talking about last week. I was going to say something actually about this nitrate. Yes, so what I was going to say is the reason that we want to dilate the coronary arteries with this nitroglycerin is because if we're having angina is means that there's an area of the heart that isn't getting enough oxygen. And so that's why we want to dilate. We want to dilate the coronary arteries to get more kind of a nice, slow, but more oxygenated blood into the heart, and that will then help with the oxygen demand in the heart and decrease the angina. Okay, hydralazine. Okay, so this medication is one of my best friends in the hospital, and the reason is that it does not affect the heart rate. All the other meds, or most of the meds that we talked about, ACE inhibitors, all of that, can decrease the heart rate. So we have to check our heart rate and our blood pressure. Now, let's say you have a patient that has high blood pressure, but they're on beta blockers, they're on ACE inhibitors, and their blood pressure is still high, but their heart rate is low. Let's say they have a heart rate of 58. Well, you can't give any more of the ACE inhibitors or the beta blockers, but their blood pressure is 180, systolic. So what are you going to do? You can't give them any more of those. So this is where hydralazine comes in, because hydralazine is a direct acting vasodilator that does not affect the heart rate. It does not decrease the heart rate. So it's a great go-to when you have a patient that cannot take any more medications that decrease heart rate, but still needs to have their blood pressure decreased. So it comes in PO and IV push. It is indicated for severe hypertension, but also, like I said, for hypertension where we can't safely adjust the heart rate either. A caution though with heart failure, because it can actually cause rebound tachycardia. So that's going to put more stress on the heart, the tachycardia. And if we decrease the blood pressure too much, then we're going to get a decrease in cardiac output, which is not really what we want. So we definitely have to monitor for hypotension here, because it is a direct acting vasodilator. And like I said, tachycardia is a normal side effect. Okay. So let's say a patient has a tachycardia of 180. Well, you can't give this either. You're going to have to go a different route. Okay. And then, of course, assess pre and post administration. So there's very little to this medication. It's a very simple medication, but it's a great additive to treatment. This is a newer drug on the market. It's called a direct renin inhibitor. So it directly inhibits the renin. So this inhibits then the production of even just angiotensin 1. So it binds with the renin to inhibit that production. So pretty much stops RAS right at the renin stage. Indications: heart failure, hypertension. There is a drug-to-drug reaction with Lasix and ACE inhibitors. So like I said, not an absolute no-no, but monitor, okay? And then the risk for this medication, there's not a lot on this medication, but the risk is hyperkalemia. So monitor those potassium labs. And of course, your kidney labs, seeing how it's working in the kidneys. So we've gone over our beta blockers. Beta blockers, just a couple of things to highlight here. Has that negative inotropic effect, so it decreases the myocardial contraction. So that's what slows the heart rate down, and it decreases the workload of the heart, which is good. Has lots of indications because it's a very good drug. Remember, it works on the sympathetic nervous system. So indications are hypertension, angina, arrhythmias. So remember, this is another medication, just like that calcium channel blocker, that works on dysrhythmias. Okay, works on like atrial fibrillation. So you can use metoprolol, for example. Metoprolol is a very good go-to to use for atrial fibrillation also. Heart failure, some side effects: bradycardia, low blood pressure, and remember, it masks that hypoglycemic effect. Do the normal holding for your blood pressure and heart rate. Call the doc if need be, or look for those orders. Monitor for weight gain. They can get peripheral edema with this. Let me see. Oh, we already went over that and went over that. It looks like I have a duplication here on this slide. So the reason that you might get peripheral edema is because it does slow that heart rate down. So if it slows the heart rate down, you typically also have to watch for that backflow of blood that would go into the peripheral. So the venous blood in the right ventricle would back up down into the inferior vena cava. So the last two here, we've gone over diuretics: the loop, which is the furosemide, potassium sparing, the aldactone, and then the thiazide, which is the hydrochlorothiazide, directly working in the kidneys. So you need to watch that PUN and creatinine, and then also their electrolyte labs, especially potassium. Okay, for the Lasix. And then aldactone, remember, it can help retain potassium. Now, our anticoagulants, when we have these heart issues, we can get pooling in, we can get a couple things. We can get pooling of blood. So if someone has atrial fibrillation, we actually get pooling of blood in the lower part of the ventricle, and that then can turn into a blood clot. And so we want to prevent that from happening because then the blood clot can be pushed out with the contraction. Atrial fibrillation, very big side effect is blood clots. Because of that, the heart is fibrillating. It's just kind of making small little jolts, not real contractions, and so again, the blood does not get pushed out properly. And also if they have an ejection fracture. So if you have an ejection fracture of, let's say, less than 35%, then remember, only 35% of the blood is being pushed out of the aorta. So that's leaving the majority of the blood still in the bottom of the ventricle. So anything that can leave blood behind in the ventricle can equal a blood clot. And so we want to help prevent those blood clots from happening, and so we give them anticoagulants.